Obstructive jaundice, caused by a blockage in the bile ducts, requires accurate imaging for diagnosis, determining the site and cause of obstruction, and planning treatment. The primary imaging modalities used are ultrasound, magnetic resonance imaging, MRI, with MR cholangiopancreatography, MRCP, and computed tomography, CT scan. Each modality plays a unique role in the diagnostic process. 1. Role of ultrasound, USG. Ultrasound is the initial imaging modality of choice due to its availability, non-invasiveness, and cost-effectiveness. Key roles: detection of biliary obstruction, can differentiate between intrahepatic and extrahepatic biliary dilation. Dilated bile ducts, biliary tree, are identified as anechoic tubular structures. Identification of common causes, gallstones in the common bile duct, choledocholithiasis. Tumors in the head of the pancreas or at the bile duct. Localization identifies the level of obstruction, intrahepatic versus extrahepatic. Limitations: reduced sensitivity in obese patients or those with excessive bowel gas. Less reliable for identifying distal obstructions or small tumors. 2. Role of magnetic resonance imaging, MRI, with MRCP. MRCP is a non-invasive, highly accurate modality for imaging the biliary tree and pancreatic ducts. Key roles: detailed biliary anatomy, provides detailed images of the bile ducts and pancreatic ducts without contrast. Useful for identifying strictures, stones, and masses. Etiology of obstruction, superior in detecting soft tissue lesions like cholangiocarcinoma, pancreatic head tumors, or periampullary tumors. Pre-surgical planning, maps the biliary anatomy to guide surgical or endoscopic interventions. Advantages: no ionizing radiation. Highly sensitive for both intraductal and extrabiliary causes of obstruction. Limitations: limited availability and higher cost. Contraindicated in patients with incompatible implants or severe claustrophobia. 3. Role of computed tomography, CT scan. CT scan is often used for further evaluation if USG findings are inconclusive or when malignancy is suspected. Key roles: anatomic localization and extent of disease, helps localize the obstruction and evaluate the surrounding structures. Detects masses, lymphadenopathy, and vascular invasion. Evaluation of tumors, differentiates benign from malignant causes, particularly pancreatic head cancer or cholangiocarcinoma. Provides staging information, tumor size, invasion, metastases. CT cholangiography, with contrast, it can delineate the biliary tree for obstruction causes like stones or strictures. Limitations: exposure to ionizing radiation and contrast-associated risks. May miss very small stones or early-stage tumors compared to MRCP. Comparative summary: modality, primary role. Limitations: contrast-associated risks. May miss very small scalable. USG. Initial screening, detection of biliary obstruction. Non-invasive, widely available, cost-effective. Limited by obesity, gas, and distal lesions. Detailed evaluation of biliary and pancreatic ducts. Non-invasive, excellent for soft tissue imaging. Expensive, contraindicated in some cases. CT scan, further evaluation, staging of malignancy. Superior for tumors, staging, and anatomy. Radiation exposure, less sensitive for small stones. Hot conclusion: in obstructive jaundice, USG serves as the first-line imaging modality to detect obstruction and provide initial clues to its cause. MRCP is the gold standard for non-invasive, detailed biliary imaging, particularly for soft tissue causes. CT scan complements these modalities by providing detailed anatomical and staging information, particularly in cases of suspected malignancy. The choice of imaging depends on clinical suspicion, patient condition, and resource availability.